السلام عليكم.
وعليكم السلام.
وعليكم السلام.
السلام عليكم everybody. جمعة مباركة. Can you hear me please?
Yes, good, perfect.
It's my pleasure again that we have a great group, endometriosis update. This is actually, it's approved from Saudi medical specialization with 4 CME for midwife, OB-GYN, and nurses. First, I know today is Friday, but it's
Yes.
We have an issue with the voice with Prof.
Yes, I think so. We lost his voice. Yes.
طيب. We were worried that something like this could happen because of the connection where Prof is in Mecca. Can we wait for him for like 2 minutes if he could come back? Otherwise, we'll proceed.
Yes, no problem. Thank you.
طيب, it's safe to say that I think Prof will take a while before coming back, and we don't want to stay lag behind the schedule. So as Prof said, I know it's Friday. Many people are committed with family stuff and other issues, but it's always good to catch up with those updates about such an important topic like endometriosis. With very esteemed figures to talk about different aspects, diagnostic and management in that field. And it's always good to start with patients' experience, as they always have their own perspective, and it will be really exciting to share that. I think we'll proceed with the patient's experience now with the first patient.
Good afternoon, everyone.
Hi, good afternoon.
Good afternoon, doctors.
Are we ready?
I will start now.
Yes, please.
Good afternoon. I'm Mary Ann, 34 years old. Have been married for 6 years and never been pregnant. I have endometriosis in my uterus. It causes me severe pain and made it harder for me to get pregnant. I have pain during menstruation since teenage years. I thought it was only bad period and dysmenorrhea. Until time goes by, I'm always suffering severe pelvic pain during menstruation and had heavy menstrual flow, discomfort with bowel movement like constipation, and sometimes pain during and after intercourse. It causes me also to gain weight and abdominal bloating. But I'm just ignoring all of these symptoms before, and when it becomes severe and can't tolerate anymore, I'm just only managing the pain by taking painkillers like mefenamic, Advil, and until Voltaren suppository. And then I would be relieved and feel better again. There is one time that I have experienced severe pelvic pain. I was frozen and can't move for a second due to the excruciating pain. And there are times also when I'm peeing during menstruation, I sense that there is something pulling down from my pelvic area and radiating until my rectum. I'm about to cry that moment, and I was so afraid on what happening to me. But still, I'm still ignoring it again. I would just take painkillers, then, but really the pain is indescribable. Then one time, I bumped into my friend, my colleague, which is working on the ultrasound department. She asked me why still until now I didn't get pregnant. She advised me to do ultrasound. So I did scan and showed there is endometrioma on my right ovary. So she advised me to seek medical attention. So I decided to visit OB/GYN doctor last January 25, only last year. I went to OB/GYN clinic to Dr. Majed Al-Hudhud. I told him everything, all my symptoms, and requested me for the official ultrasound. And it showed multiple endometriotic cysts in my both ovaries. So he did bilateral laparoscopic ovarian cystectomy exactly 1 year today. He successfully removed all the chocolate cysts and diagnosed me as a severe endometriosis stage 4. I was frightened. Then after that, Dr. Majed gave me a chance for a natural conceive. I did not take any medication for endometriosis. I feel fine and better after the surgery. No more painful menstruation. But after 6 to 9 months, I felt again. I felt again pelvic pain during menstruation. So I was bothered. Then I went back to his clinic. Again, I did a scan and there is small endometrioma again. My endometriosis reoccurred and there is adhesion in my uterus. He prescribed me medication, the same tablet, 2 milligrams for 2 to 3 months. But I took only for 12 days because I cannot tolerate the side effects, such severe headache. Endometriosis is very tough for me. It came to the point that I feel depressed, anxious due to my infertility. Dr. Majed explained everything to me about endometriosis. It will damage the egg, the sperm, and even the reproductive organ. Then he gave me chances for spontaneous conceive, only 5% in my case. So I was frightened about my condition. That's why me and my husband have decided to undergo IVF procedure. Now I'm on my IVF process, praying for the successful outcome. Now I have frozen embryo. I wish to all women to be aware of this endometriosis and know the symptoms. Don't ignore if they have the symptoms. Seek for medical attention. Awareness is very important. Either find better treatment and find a way to cure it as early as possible. That's all. Thank you.
Thanks a lot. Well spoken and nicely put. We wish you all the best with the IVF journey and with endometriosis as well. Thanks for sharing your experience.
Thank you.
Okay, can we proceed to the patient number 2?
Yes. Hello, everyone. Assalamu alaikum.
Walaikum assalam.
You hear me well?
We do, yeah.
Great. So I am also 34-year-old female, single. I'm a pharmacist by degree, and I was diagnosed with endometriosis only 5 months ago. But my journey with it started way earlier. I believe it was end of 2022 where I started to have a very severe pain during my menstrual period. It was for me unusual. So it's not like my teenage time or even previous. Even pelvis pain, bowel digestions. I had different problems. I was thinking to myself, what is the issue? I've went to family medicine. Not everything is normal. I blame it to COVID-19 vaccine even. We were thinking that this is definitely the reason, that it's just mixing everything. Until it becomes so painful that I have to seek ER. I cannot manage it myself. They do usually simple testing, even ultrasound, and they say that everything is normal and send me home with painkiller. And also I received multiple comments, you're exaggerating, it's only menstrual period pain and so on. This happened to me 7 times. With a period of 8 months, I went to ER 7 times and nobody noticed the recurrence of that. Imagine these 7 times, the pain hits me suddenly, out of nowhere, from 0 to 10, put me on the floor on a child pose. this happened to me in front of my family, once in front of my friends, in public place, even in my workplace, which is something that made me feel sometimes weak and made my surrounding feel that I have something that it's really serious, and they feel very worried about me. Nevertheless, definitely made me decide, usually not going out near my menstrual period in case if I'm gonna experience such episode of pain. After the seventh time in the ER, I decided that I cannot take it anymore. I moved from the private hospital to governmental hospital, hoping that there is something different will be there. They did the same things, test, noticing that I have small cysts on my 2 ovaries, but they are very small. It should not be the problem. Doctor decided to give me, just to mask the pain, contraceptive, and saying that let's start that, and I promised that the pain should go. I started the contraceptive, and voila, just 1 month after, I am in the ER again. I was taken from, I was in a meeting in front of my colleagues and my team member. Unfortunately, I was on the floor, and they had to take me to that. Definitely that felt so bad. Nevertheless, went to the ER. In the governmental hospital, the bullying was a bit harsher, and I was crying because of the pain, and doctor said, you should stop crying. How old are you? You cannot manage yourself. I received this comment, and it was until today I'm very angry of that comment that I cannot tolerate, and even I reported it, by the way, after.
Good.
I begged my doctor for a surgery. I said, I want you to open my stomach and just find out what is this, because I cannot tolerate it. I even gave up my summer vacation because I cannot travel and experiencing such episode of pain in a foreign country that I don't know what to do about it. After a journey of begging, finally the doctor aligned that yes, we can do the surgery. We remove the small 2 cyst. It's very small, and it is more of a diagnostic laparoscopy. After the surgery, he defined that it is a chocolate cyst. I believe I am stage 2 endometriosis, and he explained it to me. Coming from a medical field, it is the first time that I've heard of this. I never heard of it studying or even being in the medical field. He started me on Vezan from last September. Definitely, as Marie said, it's not nice medication at all, with all the side effects that it has, mood swings, headaches, but also since September until today, I never stopped bleeding. I am on consistent bleeding since then. I also visited the doctor and explained that I had drop in my iron level. I had to take iron. But the doctor said you only have 2 options. Either we move you into contraceptive, which is you have a high recurrence rate. And because I'm terrified of the recurrence rate, definitely I will not go there. Or we go into the extreme hormonal therapy that will put my body into a menopausal stage, and it is something that I don't want to do. Now, what I'm doing is just I'm sucking it up, and I'm just tolerating Vezan, which is not tolerable at all. Now, also, just one last thing. During this period, I had so many questions. Varies from recurrence rate, the effect on infertility, recommendation of egg freezing, diet effects on endometriosis, and alternative treatment, and so on. Because I started to read on that. Just to let you know that until today, I couldn't find these answers and I moved from one doctor to another. I hope that today in this forum is a starting point for a better management of endometriosis through awareness, but also through compassionate. I don't feel safe and secure when I talk to doctors about it. Still, I visited almost 4 doctors so far, and they don't take the topic seriously. They always talk to me like I am exaggerating. And with all the questions that I have, I always have different recommendations, and in a way that I feel that I don't know whom should I trust. With that, I conclude. Sorry if I took so long, and thank you very much.
Very important testimony, I would say. Thank you so much for sharing your experience. As you said, I hope this would be a starting point for a better course with this disease, my dear. Okay, well, compassionate is the word for this experience. Can we have the third one, please?
Hi. Thank you for giving me this chance today to share my experience. So I am 30 years old, MSc student. I got diagnosed with endometriosis 6 years ago. So mine started with severe pelvic pain in 2015. My symptoms, actually, it started in 2015. I used to get my period like every 12 days exactly. Until 2017, I got that severe abdomen pain, and I went to the ER. I actually suspected at the time that I was having a torsion. So when I went to the ER, they did the scans and everything, but they said there's nothing and you are exaggerating. Like if you have the torsion, you would be screaming out of pain. But when they did the scan, it wasn't obvious for them because I used to have a cyst and it was covering the tube itself. So they didn't see the twisted tube at the time. So I was referred between the back and forth between the OB-GYNs and the IG doctors, back and forth, back and forth. They didn't know what was actually wrong with me until I saw an endoscopy doctor, and she suspected endometriosis. So she did the surgery, and she found out that it was an endometriosis cyst. So, and I had a torsion, actually, fallopian torsion. So I did 4 surgeries for endometriosis so far, since 2017 until now. And I also did the egg freezing because when it comes to endometriosis, actually it doesn't scare me, but infertility does. So sorry, I'm getting emotional.
Okay, we're all here for that.
However, so before my first surgery, and since 2015, I used to have an excessive bleeding and massive pelvic pain during periods. I also used to get my periods, as I mentioned, every 12 days. So I went to an OB-GYN doctor before my first surgery, I'm talking. He did the scan and he saw a cyst, so he gave me birth control pills. So I believe that it didn't work at the time. Until I get my torsion. Maybe it was a wake-up call for me. However, so far I get like my symptoms. So far I get the pelvic pain, severe pelvic pain, bloating, brain fog. To be honest, I learned how to cope with my physical symptoms, but mentally I can never get over it. It did affect me mentally, like so much, because I am diagnosed with bipolar disorder. So endometriosis did trigger me like in so many ways. So work-wise, in 2016, I used to work in a lab, but I had to quit work because the environment and the staff, they weren't friendly actually with my symptoms and my sick days. Even though at the time I didn't know that I had endometriosis. However, when I first in my first surgery, when I did it, I was starting my MSc degree in the UK. So I was supposed to finish my degree maybe in 18 months. This until today I haven't finished. However, it made me do my dissertation on endometriosis in Saudi because like I noticed like there's a huge lack of knowledge. among the general public and the patients themselves. So when I interviewed the patient, I mean, if it's okay for me to share this information. When I interviewed those patients, most of them, they didn't actually know what endometriosis when they got the diagnosis at the time. And most of them, they had a bad experience with doctors and the ER especially. However, for me, sorry. For me, it has affected me like socially, and it did affect my education, did affect my daily activities. I can't exercise anymore. Like I used to be a very active person, but nowadays whenever I exercise, it does trigger flare-ups, and it is insane. The pain, nothing can manage the pain when it hits. There is a point in my journey where I had to use narcotics to stop the pain, but I had to stop using them because I didn't want to get addicted or something. However, heating pads, no, they didn't work for me. Painkillers, every single type of painkiller didn't work for me. I started after my first surgery. I started on Marvelon, and then when it got worse. So then I started on Vezan. It made it very, very bad. It didn't work for me. So when I went back to Marvelon, and it got better actually. But I would rather always do the surgery because it does work for me.
I know it's tough to put things in words, but
Yeah.
then again, thank you very much for this heartfelt sharing of your experience. I hope this is an eye-opener to both the audience and general population of how serious this problem could be and how it affects the lives of people who are suffering from it, which is not less than 10 to 15% of any given female population. Thank you so much, my dear, for your great experience.
Thank you.
Okay.
Thank you very much. I think this is this kind of webinar that we are sharing patient experience. Thank you for all the patients for sharing with us this information. We are learning from the patient. We feel sympathy with all of them. Thank you very much for your presentation and for all the patients. We hope that you'll get well and healthy and these diseases will be eradicated completely. Thank you very much for all the patients. We'll continue our sessions. First, I'd like, sorry for this internet connection, but I would like to thank all the participants. Our participants are from Dubai, from Gulf country, from Saudi Arabia, from France, and from Turkey. Also, our speakers from different parts, they are staying, one of them in Turkey, one in Riyadh, one in Mecca, one in France, and so it's from different participant during Friday. So I would like to thank all of them. It's for CME. This webinar is quite unique because it shares the experience of the patient with the lab experience, with the management. So I would like to thank everybody. I would like to thank Tamr Company for supporting this webinar. We'd like to see you again and again. Now we'll go for our second speaker, Dr. Majid Al-Hudhud. He's from consultant Obigani IFF Al-Habib. He's a senior consultant. He will talk to us about endometriosis and update. He is now in Istanbul. So welcome, Dr. Majid.
Thank you, Dr. Samir. Thank you for the patient experience. This is really touching. I think that also paved the way for me to go through my presentation. Because it is very important thing that unfortunately we have delay in diagnosing those cases and dealing with their sufferers. So endometriosis, as Dr. Mujahid mentioned, quite like prevalent, and we expect about 10% and maybe more of females actually around the world to suffer from endometriosis, about 190 million to some of the statistics. And to simplify things, I think we need to classify them into superficial endometriosis, ovarian, or deeply infiltrating endometriosis. I think that would make it a bit easier to deal with, although still, it's still elusive pathophysiology and physiology behind endometriosis. And it doesn't come like in one type or one symptom. It has varied clinical presentations, and that probably make it a bit difficult. And that add to the unsolved puzzle, actually, and hamper the proper evaluation of the current published studies, and therefore appropriate care for our patients. The burden of the disease has been already explained, out of work, no energy, even during the day, during the work hours, even when you want to go out, you cannot really make your plan ahead, because all of a sudden pain may happen, and then you have to cancel any planned, activities, etc., at work or with leisure time. And the medications, plus the burden of the medications and side effect of them, efficacy at some point, etc. Here is one patient actually felt that the pain is like barbed wire wrapped around your insides and someone's pulling it, while at the same time an animal is trying to eat it its way through it. So it's like really bad feeling. And again, a similar experience as with the diagnosis identified. We have the hope, and after surgery she managed to cope well with the disease, and she would love if she had this diagnosis a bit earlier. So the largest women's healthy crisis of our time at the moment is really endometriosis, as we have average of 8 to 10 years waiting time to reach the diagnosis, and 2 to 3 times higher risk if close relative has it. So we need to link things together. If we have any family history, we need to, alert the offspring. And 10 hours per week lost in productivity per woman, as our patient just mentioned, and that obviously linked to the extra cost on the economic loss. And needless to say, endometriosis, as well as also our patient mentioned, the egg freezing, etc., because we know 30 to 50% of endometriosis patients suffer infertility. So more than one in 10 women actually experience endometriosis. So this is significantly important. The myths and facts about endometriosis, that hysterectomy or childbirth is a cure. No, we should find a solution. Missing school or work due to pain is normal. No, it's not normal. We should have better control of the pain, and we can have it. The level of pain relates to the stage of the disease. No, it's paradoxical disease. Sometimes mild disease but significant symptoms, and the vice versa. We have sometimes advanced disease but no symptoms or mild symptoms. The other myth that there is no cure, well, hopefully we're working on. This is not normal, as we mentioned, regarding the symptoms and absence from the school. The common symptoms: painful periods, severe pelvic cramping and heavy bleeding, infertility, pain during sexual intercourse, painful ovulation. Unfortunately, most of patients are not aware of these symptoms or to link those symptoms with endometriosis. Urination and bowel pain, constant fatigue, bleeding, pain between periods, digestive problems, periods lasting more than 7 days, and ovarian cysts. And above all, depression and anxiety that we always unfortunately get missed by our healthcare providers. So the social stigma: there is severe lack of funding and research awareness and diagnostic methods. We will talk about it hopefully toward the end of this session. Women are forced into a culture of silence about their bodies and menstrual cycles. This is normal. You have to adapt it. You have to deal with. And many doctors, unfortunately, get misinformed about the diagnosis, and women's health is considered like taboo. And plus, there is insufficient sex education. So it doesn't provide women with the information they need about what is normal and what is abnormal in terms of pain during relationship. When it comes to fertility, the monthly fecundity rate is about 2 to 10% compared with 15 to 20% per healthy woman, so significantly affected by endometriosis. And with no interventions, about 50% of women with mild endometriosis can conceive, 25% with moderate disease can conceive, but only a few with the severe stage of endometriosis. So it can significantly affect our endometriosis. So what are the challenges in the management of endometriosis? We're looking for non-invasive diagnosis of endometriosis and clinical examination, plus imaging techniques that can give us definite answer. So that would shift toward the medical management, not only the surgical, and the surgical may be an option for the specific indications if the medications fail to do so. We're looking at long-lasting approaches for disease management because, you know, it is a chronic disease. It doesn't go with one tablet. Plus, we need to aware, like there is no cure. The woman must be aware that hormonal suppression should be maintained in the long run. And if we stop it, endometriosis may relapse. So what is the medical management available? The management actually based on few things that we need to take into consideration: age of the patient, the fertility status, the ovarian reserve, the pain intensity, the previous treatments, presence of adenomyosis and ovarian endometrioma, and the woman feelings and expectations. So the current choices of medications for treatment of endometriosis rely on hormonal medications that block menstruation in attempt to control pain and hopefully delay or avoid surgery. So medical treatment is not indicated in cases of endometriosis-associated infertility, as studies show there is no drug that improves pregnancy rates. So I cannot treat with medical treatment to suppress ovulation and suppress pregnancy to enhance the pregnancy potentials later on. When it comes to the ideal drug for endometriosis treatment, the medication should be able to cure and alleviate both pain and infertility together and become efficacious for all existing phenotypes, including the adenomyosis, and favorable side effect profile and safety profile. Also, should prevent existing lesions from progression and prevent the growth of new ones, and exhibiting an acceptable cost-benefit profile. Unfortunately, we're still looking for this ideal drug. So medical treatment is indicated for pain-related symptoms, which may be heterogeneous depending on the lesion type, the anatomical location. As we mentioned, sometimes mild endometriosis can cause significant pain if it is touching the nerves. It depends on the depth as well, because that also can cause symptoms, not just the size or the location. Other causes of pelvic pain, such as interstitial cystitis or irritable bowel syndrome, need to be ruled out, and pelvic floor myofascial pain. Those may further worsen the pain and complicate response to one single drug or approach. So we need to bear them in mind when we are treating endometriosis cases. So it's like numerous women show poor response during or after the treatment, while few may interrupt medications used due to unacceptable side effects or lack of pain relief, as our patient just mentioned. So the treatment need to be to have a special approach with combination of a few things together: the patient experience, the population health, the care team well-being, and also reducing the cost of the medication, cost of the visits, etc. When it comes to the fertility management, people tend to give long-term use of GnRH agonists in order to suppress endometriosis and then start IVF. It has been challenged as the alleged positive effects on the clinical pregnancy rates, multiple pregnancy rates, miscarriage rates, mean number of oocytes, and mean number of embryos actually could not be confirmed by current studies. So there is no evidence to suggest the long-term use of the GnRH agonist anymore. And instead of like waiting for 2 to 3 months or maybe more, suppressing endometriosis then to study IVF is just a waste of time. However, GnRH administration remains an option for pain treatment, but may result in side effects related to hypoestrogenic state, such as hot flushes, bone loss, and vaginal dryness, which can add to the burden of endometriosis. So if those happen, we can control them or counteract them by adding back therapy like estrogen and progesterone or tibolone. Apparently, such add-back therapy does not interfere with the GnRH agonist action on the endometriosis or pain relief, but it could alleviate the symptoms. So they push the estrogen slightly high to the level to alleviate the symptoms, but not to stimulate the endometriosis. And ESHRE guidelines 2022 actually states that it should be regarded as a second-line option for endometriosis-related pain, especially if patient waiting for surgery or waiting for the IVF, etc. ESHRE guidelines as well state like both combined contraceptive pills and progestogens may be used to reduce pain in women with endometriosis. And as the two are effective in pain reduction and present acceptable safety and adverse reaction profile, the choice may be based on the patient preference once they're informed accordingly. So there is no one over the other, both can be used as a first-line treatment. When it comes to systematic review, revealed that combined oral contraceptive pills used either cyclically or continuously, again, this is another question, shall we use it continuous or cyclical way? Definitely both alleviate the endometriosis-associated pain, dysmenorrhea, pelvic pain, dyspareunia, as well as improving the quality of life. However, continuous administration may prove better than cyclic, as it may produce amenorrhea and lead to better pain control. And as we mentioned, again, the same with the American Society for Reproductive Medicine, there is no specific combined oral contraceptive pill formulation has shown superiority over one another. However, there is caution regarding the quality of the studies, as the studies were of low and partially lacking the response to treatment, which reached 50%. So using combined contraceptive pill continuously may result in erratic bleeding, and we need to warn the patients about this. Yes, you will get better control of the pain, but you may suffer a little bit of erratic spotting every now and then because the endometrium will be very thin, which is manageable most of the time. And controlling the pain better, maybe by tailoring the cyclic. So maybe we can induce period every 3 months. Let's say we can use the pills back to back for up to 3 cycles, then we relieve it for 1 week. How about the medical treatment either before or after surgery? It still remains actually of dispute. The ESHRE guideline doesn't recommend the use of hormonal therapy before surgery, but can be employed to relieve pain while awaiting the procedure. The same for the infertility. Although use of hormonal treatment in order to prevent recurrence appears logical, there is no definitive studies to corroborate such approach. And Zakari et al. In their systematic review and meta-analysis regarding the hormonal treatment or placebo versus expectant management with endometriosis, they found hormonal suppression after surgery significantly reduced recurrence risk and pain. So there are some conflicting data about it, but most of the studies actually indicating that there is a place for the hormonal therapy after surgery. Grandi et al. In 2019 actually shown that both combined contraceptive pills and progestogens significantly decreased dysmenorrhea, dyspareunia, and non-cyclical pelvic pain and better quality of life. Another study back 2021 showed that although all hormonal treatments reduced endometrioma recurrence compared with expected management, none achieved statistical significance. You see, there is the difference between the two. However, Cochrane review also included evidence of very low to moderate quality, need to be bear in mind as well the quality of the studies available, concluded that the use of post-operative pharmacological treatment compared to no treatment or placebo may result in reduction of pain recurrence, disease recurrence, and improved pregnancy rates. Well, from the ESHRE, from the NICE guidelines, from the ASTRAM guidelines, as the benefits of post-operative hormonal therapy appear to be consistent, the ESHRE, as well as other guidelines, concluded that such a treatment may be offered to those who desire contraception, and the benefits remain as long as the medication is used. Once we stopped it, probably symptoms will recur, and probably if we prolong the treatment, then the remission would be also prolonged. Other modality is the intrauterine system, levonorgestrel releasing intrauterine system. It found like as a safe and effective alternative to alleviate pain, and also advisable in cases of endometrioma recurrence. It shows some like recent study that evidence doesn't support its use post-operative in order to improve the pain or improve the quality of life. However, ISHRA guideline, for instance, recommend its use to improve pain scores. And in fact, other study was with a follow-up of up to 6 months after the surgery and the insertion of the levonorgestrel intrauterine system appears to offer protection against endometrioma recurrence, which is a very important thing as well. And also improving the pain score. Plus, if you combine it also with Dynogest, I know that some patients actually don't respond to all. When you combine all the surgery, the IUCD, and the Dynogest, still they have pain. So as we mentioned, we have to have multidisciplinary approach. The intrauterine system doesn't completely block ovulation, and that's why adding or prolonging the treatment may be beneficial, and adding some progestogens also can help. In addition to the ISHRA, American Society of Reproductive Medicine and NICE guidelines, as I said, recommended the use of it for pain relief in endometriosis, and plus low or like high safety profile. So we see patients actually with the history of DVT or thrombosis, and they suffering from the endometriosis. So I guess intrauterine levonorgestrel system offer a good alternative. The new medical treatment modalities actually, some people talking about the aromatase inhibitors, some talking about the estrogen receptor modulators, some people talking about the selective progesterone modulators, or oral GnRH antagonist. The ISHRA guidelines recommend the use of aromatase inhibitors associated with oral contraceptives, progestogens, or GnRH for women with rectovaginal disease or intractable pain. So if you don't have like solutions for them, then you can consider adding the aromatase inhibitors. Regarding the selective estrogen receptor, the SERMs, and the selective progesterone, unfortunately, there is insufficient data to recommend their use in the management of pain in patients with endometriosis. What is new is the oral GnRH antagonist. This is a new actually era of the management of endometriosis-related pain. And the initial results using Ilagolex showed that better side effect profile as compared to the GnRH agonist, and significant reduction in the endometriosis-related pain when compared to placebo. However, the advantages, lack of a flare-up effect, as what we usually suffer from with the GnRH agonist, because it has immediate effect, and a rapid reduction in estradiol level, because the GnRH agonists usually increase the estrogen to start with and flare up, as we mentioned, then start acting, while the antagonist will act immediately, plus the availability of oral tablets. The drawbacks are the symptoms of hypoestrogenic status, so vasomotor symptoms, osteopenia and osteoporosis in higher doses, especially if you need to increase the dose to 200, then you have better control of the pain, but may put the patient at risk of osteopenia. And obviously the possibility of ovulation in lower doses, because it doesn't prevent ovulation from happening. So patients need to be aware pregnancy can happen despite taking it. So it's not 100% contraceptive. Plus the major drawback as well is the cost. Now, regarding the symptoms, we can also have the add-back therapy. And again, as you can see, the green level actually in the graph, that will increase the estrogen to get the symptoms alleviated, but it doesn't stimulate the endometriosis lesions. There are now 2 other oral GnRH antagonists for which trials are still ongoing. Rilogolex and has been showing benefits in alleviating pain in comparison to Leprolin, and in phase 3 studies, multi-center randomized double-blind controlled trials in Japan, but we're still waiting for the final results. And now they started to produce the antagonists with add-back therapy together to control the symptoms or the side effects from the beginning. Another promising results may be in the horizon as well, regarding the novel 17-beta hydroxysteroid dehydrogenase inhibitors, because this medication actually exerts local action blocking the conversion of the weak estrone into the potent estradiol, and then this local estrogen production remain low without affecting systemic levels. So that will affect the lesions, but it doesn't reflect on hypoestrogenic status. So the major advantage of that would be reduction of systemic effects with greater tolerability. And clinical tests should be starting soon. Finally, the Marilyn Monroe suffered from endometriosis her whole life and actually endured multiple surgeries and miscarriages due to that condition. And it suggested that her tragic death from pain medication overdose was due to chronic suffer with endometriosis pain. So to sum up, infertility-related endometriosis, prolonged administration of GnRH agonist before IVF is not justified, as it apparently does not increase success rate. Long-term of administration of oral contraceptives or progestogens before the IVF, again, doesn't increase live birth rate, so no point of putting the patient on those pre-IVF medications. When it comes to the pain-related endometriosis, blocking menstrual bleeding is essential to control symptoms, not curative, not hamper the disease regression if we don't control the period. So some people like using the Dynogest, for instance, and they say like we still having period. I mean, it doesn't like really work well with them. So you have to find another medication. You need to find the medication. You need to find another causes of pain if the pain is not really controlled, like irritable bowel syndrome, intestinal constipation, and myofascial pain, pelvic myofascial pain. Ruling out rare situations that contraindicate clinical treatment, such as suspicious ovarian mass, intestinal occlusion, or ureterohydronephrosis, which can happen also with severe endometriosis. You need to bear this in mind and investigate it very well. Regarding the deep endometriosis, the debate whether medical or surgical treatment is better remain. It's like an option, but usually the surgery then followed by hormonal therapy may be a good combination, or medical treatment until the surgery date. The evidence regarding the hormonal treatment before or after surgery, it sounds like treatment after surgery probably offer good post-operative continuity of achievement of the surgery. And disease recurrence prevention, women and healthcare providers should be aware that treatment of endometriosis should continue for years, not just like a few months. And progestogens may be a better choice in long run due to their safety, efficacy, and tolerability. Finally, recognizing endometriosis as a chronic systemic disease with inflammation, pain sensitization, mood disorders, and reduced physical activity and impact on their life, as well as investigating diagnostic tool is important, really. Increasing the public and health awareness is very important. Reducing the tragedy and the pain they suffer until they reach the proper diagnosis of endometriosis is a vital point. Thank you very much. I hope we get to the point.
Thank you very much, Dr. Majid, for your interesting lecture. If you have a time, you stay with us for questions and answer. I know that you are in Istanbul. If you like to leave us, welcome anytime.
Thank you, Dr. Samir. I will stay with you until if there is any question. Yes, I'm happy to answer. Yeah.
Thank you. Would like to welcome Dr. Majid Bukhari. Dr. Bukhari, he's a consultant minimal invasive surgery, working in King Saud University. He's sharing with us the journey with the patient for surgical management. He's sharing with us, Dr. Bukhari, journey with the patient with endometriosis. So we'll talk about surgical management with the journey for endometriosis. Welcome, Dr. Bukhari. Please join us.
Thank you. Thank you. I'll start by sharing my screen. What is that? Yeah. Okay. All right, beautiful. Again, thanks, Dr. Samir, and thanks to the organizing committee for the great opportunity to be in this scientific convention. Endometriosis has always been one of my crusades in the world of minimal invasive gynecology. As we saw with Dr. Majid and the patient's experience before, it's such an enigma when it comes to etiology, diagnosis, options for treatment, and the recurrence issues and the long-term journey we take with the patients. And among the things that are heavily disputed are different surgical techniques to manage endometriosis. And that was one of the things why I was really interested in it and wanted to share this in my talk today. Of course, given the time scope of the talk, we'll not be able to go in length in every single aspect. So we'll just try to at least touch base with different points and then focus on surgical videos at the second half of the talk. We all know what endometriosis is. Dr. Majid already talked about different locations. And he also mentioned, talked nicely about the different clinical manifestations and presentations. It's worth mentioning that you would see those in any given time of the reproductive life of any of ladies suffering from endometriosis, but mainly it presents during the mid-20s to mid-30s. 2 to 5% of endometriosis cases are also presenting in the postmenopausal age, and few cases were reported in the premenarchal girls. For diagnosis, we all know that we have two ways of diagnosis, either the definitive diagnosis when we just go in either laparoscopically or laparotomy, find suspicious lesions, remove them or send biopsy from them, and it comes back as endometriotic cells and glands outside the uterus, and we get our diagnosis, or the presumptive diagnosis when we suspect endometriosis based on symptoms or imaging or other findings, and then we start treatment and see improvement and retrospectively declare the case as endometriosis. As for the surgical staging, there's about 22 available systems for staging endometriosis. Most well known and utilized is the American Fertility Society revised classification, which is basically stage 1, minimal diseased, individualized lesions with no adhesions. Stage 2 also mild, consists of superficial implants that are less collectively than 5 centimeters with no significant adhesions. Stage 3, both deep infiltrating and superficial lesions could be there with a bit of adhesion. And then finally, stage 4 with severe disease characterized by multiple superficial and deep implants with usually large ovarian endometriomas and all kinds of adhesions. This is how you write them down and classify them. And this is how they would roughly look. Stage 1, stage 2, stage 3, and finally stage 4. It's worth mentioning that, as Dr. Majid said, pain does not always correlate with the severity of findings in the theater. Ladies could have very severe pain with minimal findings and vice versa. And I always use that in counseling my patients, that up to 15% of ladies could have classic symptoms of endometriosis. And when we go in, we find nothing. This is totally worth mentioning because it's much better to tell the patient before surgery that she has 10 to 15% chance of finding nothing, as opposed to telling her so for the first time after surgery. Most of them would not receive it well if told so. Now, for the new thing is, or relatively new thing, is the Endometriosis Fertility Index, which is also by the American Society for Reproductive Medicine, and it combines their classification system with the findings on the tubes and the history factors in the patient to correlate very well, actually. It has been validated, and multiple studies and systematic reviews have shown good correlation with the chance for natural conception after surgery. Very simple to use. You just document whatever you found about the least function status of the tubes and the ovaries in both sides and get your score, and then combine that score with the classification system also by the American Society of Reproductive Medicine and history factors, and you would get a score of maximum score of 10. And if the lady's score is about 9 to 10, then her chance of natural conception within 3 years is a little bit less than 80%. If it's 7 to 8, it's around 60. And if it's less than that, I don't think it's even worth a try, and they should go sooner to assisted reproductive techniques. Now for the treatment, For the sake of time, we'll not talk about all modalities of treatment. I think Dr. Majid nicely talked about the medical treatment in general. But overall, as Dr. Majid said, we need to individualize treatment. It's not one disease with one treatment option or two. It has to be individualized based on the clinical presentation and reproductive desires, the severity of symptoms, the extent and location of disease based on surgical findings or the initial imaging modalities, age of the patient. I would not think of surgery as a good option in ladies who are perimenopausal, not at least as a first option. And finally, medication side effects in terms of certain high-risk categories of patients or the undesirable, relatively more common side effects according to the patient's experience. And finally, complication rates of surgery and the cost depending on the insurance status of the patient. Okay, so the advantages of the surgical, I'm biased because I'm a minimum invasivist, but let's talk about the advantages of surgical intervention, of course, confirmation by histopathology, assessment of pelvic masses or cysts, reducing pain by destroying or totally removing the endometriotic implants. On the other hand, the disadvantage, of course, surgery is surgery. There's risk for injury, possible reduction of the ovarian reserve, especially when dealing with endometriomas. It has been clearly confirmed, and patients should be clearly counseled about this before going to surgery. Adhesion formation, of course, we have different mechanisms, and it's a whole talk about how to reduce adhesion formation, especially in endometriosis surgery, but nonetheless, it's one of the drawbacks. And the standard generalized surgical risks other than the risks associated with endometriotic surgery. So who would we take for surgery? Of course, patients who have persistent pain despite single or multiple medical therapies, people with contraindications to different medical hormonal therapies, or if they refuse to do so after being counseled about the side effects, need for tissue diagnosis, and of course, exclusion of malignancy and adnexal mass. And if the lady has severe bowel or urinary symptoms, bowel endometriosis could happen in about 7 to 9% of all the endometriosis patients, and bladder endometriosis could be present in up to 3% of endometriotic patients. So in case of severe bowel or bladder symptoms, then surgery, the threshold for surgery may be lower than in other patients. When to avoid it, as we said, women with incomplete evaluation of pelvic pain, surgery would be unnecessary in this stage. I think full evaluation is better, as other etiologies, like Dr. Majid mentioned, could be thought of ahead of the endometriosis. Women with persistent pelvic pain after repeated surgeries, we'll talk about the chance for repeated surgery to relieve pain and improve the status of the patient. But in general, the more surgery that is done, if done properly, the less the chance for success. So if I did the surgery myself, or if I knew the level of the colleague who did it, and I know he or she were very thorough and radical with endometriotic excision, then I would think twice before taking a repeated surgery as an option. And of course, women nearing menopause, at least not as a first or second option, given that the vast majority of patients, 95 to 98% of patients, would not have issues after menopause. So in surgery, we have the conservative arm and the radical arm. Conservative should always be the first option when surgery is undertaken. And it basically consists of excision or ablation of all the endometriotic tissue and preserving as much as we could of the ovarian tissue in the process. It has the advantage of preserving fertility logically and hormonal production. It's less invasive and morbid if the case is not that severe. And it has well-documented short-term and long-term efficacy as well, especially with the help of post-operative hormonal treatment. On the other hand, the rate of recurrence is high, and we'll see that in a moment, and the rate of reoperation increases over time for conservative surgery. This is an interesting retrospective study that followed 240 patients after either conservative or radical treatment, surgical treatment of endometriosis for 7 years. 120 patients underwent conservative surgery, 120 patients went hysterectomy with or without oophorectomy. And I always use these figures in my counseling of patients. You could see in a window of 7 years, about half of the cases were surgically free, but the other half ended up having another surgical intervention. About 80% of women who underwent hysterectomy with preservation of ovary were surgically free, but 20% required further intervention. And even in women who underwent hysterectomy with bilateral salpingophorectomy, about 10% of those women ended up having another surgical intervention. Of course, as Dr. Majid said, contradicting data about the role of postoperative hormonal treatment in reducing those figures. But nonetheless, for this part of the talk, I think that counseling the patient about such figures per se is quite important in managing their expectation. Same figures mentioned in the diagram a moment ago. Okay, so here's a passionate topic for me, ablation versus excision. Just to show my conflict of interest, I'm an excision person. I always think that excision is much better than ablation. And I always get slammed with those RCTs and systematic reviews showing that ablation is equal to excision in terms of pain relief when it comes to superficial endometriosis. And my response to that is always, it is for superficial disease. And the issue is that without going retroperitoneal, you would be surprised of how many lesions that are looking superficial, but they're actually deep. And we will show videos of that. So you wouldn't know for sure that it's superficial in some lesions. Yes, with some lesions, it's quite obvious. Peritoneum is moving nicely and freely, and below it, it's healthy. In those cases as well, I'm still doing the excision because of the benefit of histopathology. But in other cases, you would not be so sure that it's superficial, which means that you could ablate superficially and leave whatever inside deep to keep going. And it's not a recurrence, it's just failure of surgical intervention. And the second thing is that near vital structures, most, if not all people, would refrain from ablating as much as they want to destroy the endometriotic lesion because of fear of thermal spread and injury to vital organs. And in those cases, excision would be the only way. And if so, you cannot just pick and choose which one to excise and remove, because in Arabic we say أيوم الكريهة تراوض الخيل. You cannot train your fellows or residents to do enough excision if you're not doing excision all the time. And they cannot suddenly know how to do it in deep, difficult cases when they don't know how to do it in superficial cases. The learning curve starts with doing excision for superficial implants, and it goes in a steep fashion to be able to do it with the deep lesions. So in short, I do believe that excision is much better, despite the lack of evidence. And the ESHRI guideline, the latest one in 2022, also prefers excision over ablation. Okay, so definitive surgery, which is of course hysterectomy with or without oophorectomy. And the candidates for that are definitely patients who failed medical and at least one conservative surgical trial. And usually they are with no desire for future childbearing. And of course, the role of oophorectomy, definitely, if you do oophorectomy bilaterally, you reduce the chance of recurrence of symptoms or need for reintervention. But given the significant risk of losing the hormonal function of the ovaries at a relatively younger age, there were some studies that showed that life expectancy of women who had oophorectomy before the age of 40 is dropped by 3 to 5 years. That's quite significant. So in young ladies, and this is mentioned in the ESHRI guideline, it would be prudent to leave them at least with one ovary. Oophorectomy alone has never been shown to be effective enough and definitely would not be an option, given the loss of hormonal support with all the price women pay for that and no significant benefit. The disadvantages, of course, loss of reproductive ability, higher surgical complications, and negative impact on body image, which is quite significant. And if we go more through the patient's experience, they would have told you so. And the early menopause, of course. So laparoscopy versus laparotomy. Different studies showed no difference, but I think given the overall benefits of laparoscopy over laparotomy and the magnification of fields, much better visualization of different planes, I think it comes without much thinking that laparoscopy is the path, unless there's a specific contraindication, which is also mentioned in the latest ESHRI guideline. Medical therapy, Dr. Majid talked about it nicely, mentioned in the ASRM and in the ESHRI guideline. Okay, so Repeat surgery. There is a paucity of data regarding the success of repeat surgeries. One of the few studies, systematic reviews of studies published, and it only revealed 3 studies. And despite the very poor correlation between different studies, we could roughly say that there is a risk of 20 to 40% of pain after subsequent surgeries, and about 15 to 20% chance for a third or fourth intervention. And those figures, again, should be shared with patients in counseling. Okay, now the interesting part, inshallah, I'll not take more than 10 more minutes. How do we do it? So we'll start with different videos. Again, all excision, few ablation of whatever remains. We'll go from stage 1 to stage 3 and then specific conditions. So here we have a lady. Again, all the ladies in those cases were extremely symptomatic, so we were radical in our conservative approach. And as we all know, endometriosis could present with the classic gunpowder lesions, but they could also present with the red erythematous patches, or sometimes just pale white patches. And some experts theorize that actually the gunpowder lesions are the lesions that already fulfilled their course, and the most active lesions are the white patches around those gunpowder lesions or without them. So in this young lady, you could see a lot of, a lot of white patches in the right and left pelvic side wall here and there, and angry erythematous peritoneum. So we decided to go for extensive excision of endometriotic whitish patches, given the fact that she's quite symptomatic. You see, we're using gas to inflate the subendometriotic planes, and we're avoiding excising any healthy tissue to decrease bleeding and be as neat as possible, yet very radical as it requires. You could do it in one piece or multiple pieces as long as you're going to remove the whole thing. You could see whitish patches and a bit of angry peritoneum on the left side. We're dissecting with the scissor all the unnecessary areolar tissue below to avoid bleeding, and we're sparing even the small blood vessels here that do not require excision, and they're quite healthy. You see this shiny layer? This is the subperitoneal plane. So keeping it intact would mean that you're preserving all the vital structures below and reducing bleeding. It makes the surgery easier and better. Nonetheless, you remove as much as possible. See, again, more angry peritoneum. So we're removing all of that without having to go below the subperitoneal plane. Okay, now on the right side, you can see the ureter here. It's clearly away from what we want to excise. Ureters are not usually involved in the very superficial endometriotic lesions, but again, red erythematous plaky peritoneum, so I'd prefer to remove it. But in the right side here, the lesion is a bit close to the parametrial area, which means that uterine artery is not that far, and that should be kept in mind to avoid unnecessary bleeding and much more difficulty encountered. See, it's not that far. We just push it away with the scissor and then cut the entire area rather than just ablating it. Eventually, yeah, one more thing. That pocket we saw initially in the pouch of Douglas, the Allen Master sign, again, removing it, but here we're pushing a rectal probe so that we could push the rectum as far as we could to the left side and then work on the right side to be able to remove the entire pocket safely. This is the posterior vaginal wall. Again, all healthy tissue below, so we did not leave any lesion. Being as radical as we should would decrease the chance for recurrence. Again, more patchy lesions found here in the right pelvic side wall. You could see that lesion here, so we decided to go for excising this part as well. And again, when you have bleeding, it is worth dealing with it while you still have traction by the specimen you want to excise, rather than cutting first and making that bleeding part retract all the way back to the original spot and get much closer to vital structures. There you go. Okay, so that's how it looks after excising whatever we suspected, because this lady was highly symptomatic and we did not leave anything for chances. Okay, next case. This is stage 3 with multiple deep infiltrating nodules in the right and left side. You could see here that the ureter is, alhamdulillah, away from that nodule. And again, instead of just buzzing it, we went all the way to excising it completely. Healthy tissue below us so that we know we're as radical as we should. And we go layer by layer, given the sensitive area. Uterine artery is going to be here. So want to be very superficial. Bit of endometriotic secretions here. Okay, so that's it. I wanted to show you something here. You see when it suddenly gives away, see that when it just gave away, it shows you that this tissue is healthy. If that tissue was fibrotic and endometriotic, it would not have given away so quickly like a spring here. That's a very good sign that would tell me that I was radical as I should be when I removed that nodule and all the tissue left behind is healthy. Okay, now in this pararectal lesion, it is quite interesting to see that when we pulled a small part of that endometriotic lesion in the left pararectal area, a big lump came with it without me holding it, which shows that this is all fibrotic and possibly all endometriotic. And people really fear going into the pararectal area. It's totally safe to do so as long as you have fat below you. Fat is your friend. So as long as there's fat between you and the rectal serosa, and you're being conservative enough with your monopolar energy, then you're totally safe. Despite how the rectum is not going to be as far as people would think, and as I will show in a moment. So excising the whole fibrotic area with the lesion here, because that lump came with it. It's attached to it, so it has to go. It's not healthy. Again, here, you see that whatever we're leaving behind is totally healthy. So we know we have a good safety margin with our excision. Okay. Now, again, while cutting, if you face bleeding, usually a small amount, do not hesitate to deal with it before cutting the whole lesion, because the traction applied by you holding the lesion keeps that bleeding area away from whatever vital structure below it. So I have a bit of bleeding here. That would have stopped if I left it, but only after contaminating my field enough and making it less tidy and more bloody. So just deal with it with short bursts of monopolar or bipolar energy according to preference and how safe it is, given that the distance between you and the rectum. You see, rectum is not that far, but as long as you have fat between you and the rectum, you're okay. Another nodule in the pouch of Douglas, dealing with it similarly. Okay. All the way down to here. There you go. Now, this is a tricky lesion. This lesion is at the level of serosa. So you see when I'm dealing with the level exactly adherent to the serosa, I'm using cold cut. That's an option. Okay, and I can deal with whatever bleeding with short bursts of bipolar energy after. I can see Dr. Samir looking at me. I have less than 5 minutes, then I'll be done. Okay, so we're done with that. Again, complete excision instead of just buzzing. Again, right uterosacral lesion, but you could see that the uterine artery is so close, so we have to be careful with that. Just excising whatever is not healthy and leaving healthy tissue behind to be as radical as we should. Okay, and voila, there we go. The whole lesion that was here is gone. One more interesting case, which is endometrioma. We talk about reduction in ovarian reserve with endometrioma, which is inevitable. You will have reduction of ovarian reserve when you're dealing with endometrioma, but I think certain techniques could reduce that reduction. After mobilizing the ovary, of course, we just mark our line where we want to go and cut. Now, people always talk about true endometriomas not having a cyst, that is just a collection, which could be true with small cysts like 1 or 2 cm, less than 3 usually, where you don't have a cyst clearly. But here in this case, there is clearly a cyst, and some experts try to find a midline between these two arguments in saying that big cysts, big chocolate cysts, are basically innocent cysts that got later infected with endometriotic cells. They got implanted inside, and then they grew to this level. Here, I tried to do as much as I could of the excision of endometrioma in an intact fashion. I only managed to do a full intact endometrioma once, but usually at some point, it would break and you start seeing chocolate. At least when you do so, when you try to do as intact as you could, the distension of the cyst would serve to show you the plane in a much better way. So you do as much as you could. And then when rupture happens, you would just go in, and this technique, I usually call it the beating heart technique, which is basically going in with a suction and then pushing a lot of fluid and sucking it repeatedly in cycles so that you would clean the cyst and reduce the amount of spillage of chocolate material into the field. It would be very disturbing to see how the field is quite contaminated with all endometriotic secretions that could implant there and cause future problems. After that, we remove the cyst exactly at the plane level, trying to preserve as much ovarian tissue as we could. You see here, we're just stripping the cyst away and keeping the ovary. I know this is not achievable all the time because of the fibrosis at the plane we could find, but at least in cases that do not have much fibrosis, we try to preserve as much ovarian tissue as we could by doing so, and also by avoiding excessive use of bipolar or monopolar energy. Just, oh my God. Just buzz whatever that is clearly bleeding. And for the small bleeders, you could resuture the ovary. This technique is undertaken by major figures in the field of minimum invasive gynecology, like Professor Watiz. And it does reduce the need for...
Sorry, Dr. Mujahid, 2 minutes more.
Yeah, more than enough, inshallah. A need for coagulation. Now, in this lady, just we skip one video for sake of time, this lady had a major nodule in the right pelvic side wall, and you could see that the entire peritoneum is denuded here as well, and the nodule looks innocent, okay? But the more we dig, the more we find of how big it is. And we also have parametrial lesions. So we dealt with, first we raised the ovary to the anterior abdominal wall. It's tricky to use a straight needle, but in no time you'll find yourself so familiar with it. And it relieves your assistant. Instead of holding the ovary, they will be assisting you with other stuff. So we dealt with the parametrial lesion, similarly to what we showed before. Mind you that this is the uterine artery. So it's few microns away, and we should be very careful to avoid unnecessary bleeding. And after removing it, we just started to do our erythrolysis. And the more we dig, the more we realized how big the lesion is. So we're digging, the ureter is all the way here above me. And all of this, you see my scroller, all of this is an endometriotic, deep infiltrating endometriotic lesion that was much bigger than when anticipated initially when we saw it at the peritoneal level. And that's why I think ablation is not the best, because if we saw that from above, we could just buzz a little bit, not knowing how deep it went. And look how deep it went. It's really a big lesion. I had to remove in several chunks. But the more I dissected, the more I realized how adherent the ureter was. In most of my erythrolysis, it's just pushing the ureter away from whatever the lesion is. But in that case, the lesion was encapsulating the ureter, which is quite challenging. So decided dissecting the ureter from a healthy point, moving to the diseased point to know exactly the course of the ureter. You could see the ureter now behind my bipolar grasper, and I'm dissecting the entire nodule here away from the ureter. Okay. Okay, there you go. So now we have a lesion, and we created a plane between the lesion and the ureter. This is the ureter, this is the lesion. We're winning here. Again, more space created between the ureter here and the lesion. without the need for our friends in the urology. I think most ureteric lesions could be dealt with sufficiently trained gynecologists, because the approach in urology is a little bit different and we prefer our own way. You see, now we're cutting more of the nodule, such a big one, away from the ureter safely. Okay. And then cutting the entire thing. Sorry, I'm skipping just to catch up with time. Cutting the entire nodule. Look how big that was. You could not have ablated that enough when being so close to the ureter. So, and then again, just to show you how engulfing it was, after dealing with whatever left of the lesion, this is my last bit, Dr. Samir. Yeah, more of the lesion was still above the ureter, so we had to dissect. And you see, when we're cutting here, totally healthy area. So we know that we removed the entire big nodule, several centimeters nodule, that was totally engulfing our ureter. And then we did cystoscopy and found that the ureter is fine. And this is how it looked eventually. I thought I have time for the rectal shaving as well to show you how we deal with rectal lesions that are not totally involving the entire thickness of the rectum. But of course, that's the last video. I have no time to include that as well. That's how it looks eventually. Look how big the area was and tell me if ablation could have dealt with that. Again, sorry for the prolonged time, but I tried to include as much as we could from our experience in dealing with endometriosis. Thank you very much.
Thank you very much, Dr. Mujahid. Now we move to interesting part. After you hear medical treatment, you hear surgical, we'll go for interesting part, something new. Endo test, easy to collect, easy collection, but reliable result. Dr. Ahmed Saad, he's a clinical pathologist, PhD degree in molecular biology and molecular immunology. He's from Al-Farabi Laboratory. Welcome, Dr. Ahmed Saad. So join us to hear from you. After we hear from doctors, now we'll go for labs. Welcome.
Welcome. Thanks a lot. Welcome to all my colleagues. Now I'll share my screen. Nice to meet you all. Is the screen appear to all?
Yes, we can see it.
Yes?
Yes.
Yes,
now we'll speak about guidelines for the use of ZEWIG endotest. ZEWIG endotest is an in vitro diagnostic device for the use by healthcare professional only for diagnosis of endometriosis from a saliva sample. ZEWIG endotest is a non-invasive diagnostic tool based on the analysis of the salivary microRNA via next generation sequencing and also by artificial intelligence. Advantage of ZEWIG endotest is a clear positive or negative test with rapid diagnosis. Also, all forms of endometriosis can be diagnosed. It's with high reliability, close to 100%, with sensitivity more than 95%, specificity more than 95%, and with a diagnostic accuracy more than 95%. It's a simple, non-invasive sample collection. Indication for use of ZEWIG test. It's intended for patients between the age of 18 and 43 years with symptoms suggestive for endometriosis, as chronic pelvic pain, dysmenorrhea, deep dyspareunia, dysuria, also painful defecation, painful rectal bleeding or hematuria during menstruation, also pain in the shoulder tip or infertility. The reason for or situations in which someone would use a diagnostic tool. Patients with suggestive symptoms of endometriosis and when imaging examination results are normal or equivocal before empirical medical treatment. Patients with persistent suggestive symptoms of endometriosis despite medical treatment and when imaging examinations results are normal or equivocal. Exclusion case, endometrioma or rectosigmoid endometriosis found on ultrasound or MRI examination. Also, Zewick test is a prescriptive use only device, and saliva collection must be done under supervision of a healthcare professional. Limitations regarding the population. The patient must be at least 18 and no more than 43 years of age at the time of testing. The patient must not have a history of cancer or HIV infection. The patient must not be pregnant at the time of testing. Zewick endotest is intended for female patients only. Zewick endotest can be performed under hormonal treatment. Zewick endotest can be performed at any time of the cycle. Sample collection precautions. Test results depend on the quality of the sample collection, storage, conditions, handling, transportation, and storage at all stages. Poor control of collection or transport or storage or handling may result in incorrect test results. Zewick endotest is a pre-analytical precautions during the sample collection. The patient must have clean, soap-washed hands and must not show signs of acute infection, not drink within 30 minutes of collection, not eat within 30 minutes of collection, not smoke within 30 minutes of collection, no chew gums within 30 minutes also of collection, no brush teeth within 3 minutes of collection, no rinse mouth within 30 minutes of collection. It's preferred to take the sample in the morning on an empty stomach. Collection should only be done under supervision of a healthcare professional. Control of samples. The collector must perform 3 visual checks. Verify that the sample kit components are free of defects. Saliva verification. The amount of saliva must reach 1 cm about the indication line on the tube, as we will see. The appearance of the saliva mixed with stabilizing liquid must be clear and transparent without discoloration, food, and all any residue. Verification that the kit expiry date haven't passed. If one of these 3 controls show an abnormality, proceeds to a new sampling for the patients, as we see in that figure. Clear sample for saliva. Storage and preservation of specimens. Once the sample has been taken, it must be sent to the lab. Within 7 days, the sample can be stored at forced release for maximum of 7 days before sending it to the lab. Interpretation of the results. 3 types of results are possible for Zewick endotest. A positive result from Zewick endotest is in favor of the presence of endometriosis in the patients. Also, a negative result from Zewick endotest is in favor of absence of endometriosis in the patient. An invalid result, the sample and or the sequencing file cannot be analyzed or it's not interpretable. Medical management of the patient must be based on all the available clinical and biological data. Results are provided to healthcare professionals on average within 3 or 4 weeks from the date of reception of the sample by the laboratory. Thanks a lot.
Thank you very much for your interesting and short lecture, but it's highly conclusive. So thank you very much. Stay
Thanks
with
a
us
lot.
until the end.
Okay.
Now, with something, usually gynecologists, we hear about pap smear, we hear about endometrial specimen, serum test, hormonal test, something new. We are going to talk about saliva test. I think we have one expert, Prof. Soufiane bin Daifallah. He's from France. He's a professor of gynecology obstetric at American Hospital of Paris, where he's the head of Endometriosis Expert Center. He published more than 250 scientific works related to endometriosis and gynecological cancer. He's expert surgeon in endometriosis. We hope one day in Saudi Arabia we are going to have endometriosis center, and we are going to invite you, Dr. Soufiane, and all the people who are interested in endometriosis. Welcome. We want to hear from you about saliva test so all gynecologists are waiting to hear from you. Thank you.
Thank you very much, Dr. Cindy. I'm very proud to be here with you this afternoon, and I hope also that Arabia Saudi will have soon an expert center with dedicated doctors and dedicated to those patients. I would like to just share my screen with you, and we will, of course, because we are here to discuss the saliva test, and we are going to discuss what happens now beyond the horizon, especially beyond the horizon of the scientific data. As you know, 95% is the accuracy, the current accuracy of the Endo test. And this accuracy is really for me important, especially my wish when we start this adventure of the new saliva test. And my hope is especially dedicated to patient because I do believe that now, due to this new test, we will overcome limitation of exam, sonography, MRI, and of course, we will overcome what happens in the care pathway of those patients. 95% is objective accuracy of the Endo test. And as you know, we will now be able to change 10 years of wandering, 10 years of suffering by 10 days of hope. And this is, for me, as a doctor, as an expert surgeon, the most important fact of the Endo test. Behind the technology, behind this innovation, there is patient, and this is what we believe. We believe that in the next future, we will change the life of those patients, young women, especially because we will give them a new and accurate and precise information. And this is a game changer. Why this is a game changer? Because you know, and it has been reported by patients, it has been reported by doctors, the delay of diagnosis is associated with wandering, and of course of suffering, and of course by many investigations, and of course by discrepancy between what the patient said, what we found, and what we can help them. And as you know, during this period of diagnostic, we will have impact on social life, impact on family life, impact on career, and many other impact of those patients. That's why we believe that starting the journey of endometriosis by a diagnostic test accurate will change all these consequences. And the most important fact, and I hope this test will be used at this good level, especially to remove and to overcome stigmatization of those patients. This is my only hope. My 3 key points are saliva. As you know, the Ziwig Endo test and the saliva test is the first test worldwide able to show that inside of the saliva, we found RNA and microRNA. And thanks to those all microRNA, we are able to define a signature sensitive, specific to the endometriosis. And this innovation is the combination of artificial intelligence and microRNA, all in a simple collection of saliva. And this is really a new innovation in the area of the diagnostic and in medicine. That's why, as you know, we win many prizes. And as you know, we win 2 years ago, the Prix Galien, which is one of the most famous prizes in science and innovation in France and Europe. My 3 key message. Now we have the data, the conclusive data of our 1,000 study able to advocate the usefulness of the Endo test for the diagnosis. We also advocate the usefulness of the test for infertile women, especially to improve, to change the journey for those patients. And because we change the diagnosis and because we improve the care pathway for infertile women, of course, we are able now to dedicate all our time to the care pathway of those patients. And that's why I hope one day soon, Arabia Saudi will have an expert center dedicated to all these aspects of the care. Now the data. As you know, I presented those results last year. This is the result of the interim analysis. And the interim analysis was based on one part of the population of 1,000 women. And last year's, I show you the result, which are sensitivity, specificity, and the accuracy, the overall accuracy of the test is 95%. Those results in the interim analysis have been also reported in the final result of the study, which is now in press and in publication in one of the most famous journals in the world. And those results are really important to understand why. Because this is the first time, whatever the issue in endometriosis, this is the most important study in the world. 1,000 women with endometriosis, with control patient, have been enrolled in this study. And we add to the knowledge of the endometriosis world, those new data. First fact, 95% of accuracy. Second fact, this is when we compare this accuracy to MRI, to sonography, the endotest is of higher accuracy than the routine exam. And this is, for me, the most important idea to explain why and how we can use it. Very simple. Now, this is the most logical care pathway for patient. A patient came to see you with pain and with suggestive symptoms of endometriosis, like in ESHRE guidelines. You can perform sonography and you can perform MRI. In this issue, you will find endometriosis because the results are clear. At this moment, it is not necessary to use and to perform the endotest. You should and you must treat your patient as you know by medical or surgical therapies. It depends. Second option, because this option has been written in the recommendation, is to start an empirical treatment for patient. And at this moment, you have kind of difficulty. You have patient with pain, normal imaging. You can start this empirical treatment, but you must do the endotest, especially to have an answer about the diagnostic. And the last option is the option of the discrepancy. You have symptoms, you have no result at sonography or MRI. At this moment, this is a high value of the endotest, especially for most complex disease, most complex patient for whom this imaging exam are normal or equivocal. And as you can see, the endotest has to be performed for this subpopulation of women for whom the sonography, either the MRI, is not able to give an answer. This is for us the most practical and the most logical utility of the endotest. Second utility of the endotest, fertility. Fertility, I would like just to share with you some fact from the guidelines of ESHRE. All of you knows the mechanism of infertility. Simple. But all knows also that IVF can be an option for women with infertility. But surgery can also be an option for early stage of endometriosis. And for the later stage, the surgery has to be balanced between the benefit and the risk. This is guidelines, which at the moment can be interpreted as if you have infertility, you can use IVF or surgery or a discussion between you and the patient. As you know, IVF had a good result, between 30 and 40% of result. But you also know that surgery may help to spontaneous conception after the surgery. I also reported several times the added value of surgery, especially for the most complex disease, where I showed the value of this surgery, even you have colorectal involvement. If we want in the next future improve the pathway of those patients, we have several options. That's why we work on this issue of infertility, endometriosis, and the value of the saliva collection. How the saliva collection may help to improve those patient care pathway. This is what we believe. If we take into account what it has been published, if we take into account the value of the test, especially the value of the test over the MRI, over the sonography, we think that front of an infertile woman, you must perform the test. If the result is negative, you must continue to follow the fertility workup of this patient. If the test is positive, at this moment, you will have two options, IVF or surgery. But you can also perform IVF before surgery or surgery after IVF. And there is enough data now in the literature to protect and to say those two options are equal front of infertile women. And the role of the test, especially for this subpopulation, is to reduce the delay to go to the IVF or to go to the surgery. At this moment, you have infertility, you have endometriosis, you should perform IVF or surgery. And the data are very clear on this point. This is for me the second issue where the tests have a value. Beyond the horizon, as you know, we are working on microRNA, and those RNA are like the star in the sky. We are already able to make combination of those RNA, especially to open the door of the molecular biology for endometriosis. This door has been opened in cancer. Now we will open it in endometriosis. How can we open it? We will open the door for young women, for teenage women. As you know, we have a study. We are close to finish this study, and soon we will be able to give you data, to give you knowledge about the value of the test for young women, most youngest women of teenager. We also be able soon to give you new information about the disease, which is called the biological phenotype. Like in cancer, we will find a biological phenotype of endometrial cancer, for example. Soon, we will be able to talk about endo, not like stage 1 or stage 4, but like endo, which biological phenotype of this one, And this is for me, soon, the horizon for endo. To conclude, as you can see, now we bring the knowledge of accuracy with the most highest population study in endometriosis, whatever the country, whatever the topic. We show its reliability in terms of biology. We show its simplicity. You just have to perform this saliva collection. And of course, for me, the most important fact, it is his non-invasivity, especially for patients for whom all the care pathway has always been associated with wandering and suffering. Thank you very much for your attention.
Thank you very much, Prof, for your interesting lecture. Just only I'm thinking, now society has been changed. So do you think that you encourage patients to do saliva test because to do freezing of the offer because endometriosis is a progressive disease? So for future, you will get easy pregnancy and have good quality of egg?
I think it will be the next door also to open. But as you can see, Dr. Sandy, there is many doors to open in the same times now. But yes, of course, if we have an early diagnosis, we will prevent the impact of endometriosis on fertility. And of course, we will discuss the egg freezing soon and at the early stage with a good quality. I totally agree with these comments.
Yeah. Now, endometriosis patient has a long journey, 10 years of hope, 10 years, 10 days to have the test. What is your advice to our generation, Saudi generation, when and to do the test, if needed?
I have two, yeah. For me, as you know, your country is one of the most important country worldwide, and now we will be in my knowledge of on the test, we will be the first after a few countries in Europe to use it. And because you must show to the world how your generation of doctors will improve care pathway of your patient. And this is for me, you must be the first big country to say, okay, now we are able to reduce all the delay, all the journey of those patients, and to show how we can treat most early and most better those patients.
My question to Dr. Ahmed from the question and answer from the lab. How much time, because Dr. Sufyan, he said 10 days, how much time it needs to get the result in Saudi Arabia? Hello? Dr. Ahmed Saad, you are with us?
Dr. Samir, allow me to answer the question.
Yes, please.
So the test needs 10 days in the sequencing part and the artificial intelligence. You need to add to this the time of collection locally in the country and the send out. So you need to add almost, let's say, 2 weeks, the time to be received and treated and results. So by the end, it's maximum around 4 weeks to be received at the doctor level.
Thank you very much. My questions to Dr. Sufyan, actually, what about adenomyosis? Some of the patients, it's actually asking what is their future for fertility issue, for early diagnosis, especially some of them, they have progressive disease reaching to adenomyosis. So what is your advice to those patients, especially if they go for IVF?
Yes, we discussed this point in our last study, and we have the data about the accuracy of the endo test for women with adenomyosis, and endo. And the accuracy of the test is very high, especially for those patients who have only adenomyosis, which means now, if you are faced with a patient with symptoms suggestive of endometriosis, the test will help you to screen these two populations, and of course, to screen the population who associate those two conditions of endo and adenomyosis. The accuracy is very clear for us, and the publication, which is now in press, we include the data about all those results, showing how the test is able to screen these two populations, especially with adenomyosis.
Dr. Sufyan, the question is how you position today in Saudi Arabia the test for diagnostic, and how you position it for the infertility. When and after what you will position the test?
For me, for infertility, the test has to be performed very early. You have an infertile woman, you need to perform hormonal testing, and also at this moment, you must perform the endo test, especially to be able to say there is endo or no endo. And if there is endo, you have to short the care pathway associated to this. Very early for infertile women. And in terms of diagnosis, the test has to be used, in my opinion, behind MRI or behind sonography if you are the doctor who performs sonography. If you have symptoms, your exam is normal, at this moment, you must do it.
One is asking in the questions and answer, is the test available in Kingdom of Saudi Arabia and in which town? Dr. Alina, if you could answer these questions.
Sorry, can you just repeat the question? Which town we can find the...
They are asking where is it available, the test in Saudi Arabia until now, and in which town?
Okay, it's available in the whole country, and our partner is Tamer Group. You can contact Tamer Group. He will guide you to the lab that is allowed to take the test and send it out. So Tamer Group, I think we can send the email of someone on the webinar immediately, so he can be contacted.
Yeah. You can put it in the screen, so if you like, so add it in the screen so people, they can communicate for patients who are in the need for the test. My question is to Dr. Mujahid. Hello, Dr. Mujahid, you are with us.
معكم بروف الله يحفظكم.
It's nice to hear that different things, life test, management, medical management, surgical management. Always there is conflict between surgical, medical, when to operate, experienced surgeon. So what do you think about doing more investigation and for this one. What do you think, especially now the medical legal issue raised up, complication of surgery increased, we don't have expert person in endometriosis?
Absolutely agree, Prof. I think that despite me preferring surgery in certain cases, it should not be the first thing to come to mind when dealing with endometriosis. I mean, surgery could wait until either we have sufficient reason for it or other methods have failed. As in my approach, patients will be stuck with hormonal treatment before surgery and after. If we could avoid surgery, if medication worked perfectly, or if the patient did not have a significant indication, I would really prefer not to do it for every single one we suspect with endometriosis. And as you said, complications when it comes to surgery are way more common and serious when compared to medical treatment. So as much as possible, if it could be avoided, then better, unless, as Dr. Majid and Prof. Sufyan said, if it's infertility, you can't give most of the medical treatments. So you're kind of stuck with that, or if medical treatment fails. And the second thing is that it would really be preferable if there was a clear pathway of who does what. I think the stigma of failed surgical intervention is huge, because it could be failure of method rather than failure of surgery overall. If it could be limited to people with certain training and a certain approach, then I think the number of failed surgical interventions would not vanish, but would definitely decrease, as well as the complications associated with it.
Now, I think this is a good time that we have patient with us. Patient number 1, number 2, number 3. So now we hear from doctors. So let us hear from patient if any of the patient number 1 or number 2 or number 3, especially some of them, they have long journey. What do you think about such issue to be actually available? If any of patient number 1 or 2 could, especially one of them had history of infertility, one of them, she has long journey. So if you want to comment, please comment. We are waiting for your comment as a patient. Yes.
I just want to comment, Dr. Samir, about the tests. I think it's a really great hope for patients, and we would like to have it available in each and every center for patients to just at least relief. I know that the diagnosis is not the solution, but it's the first step toward the solution. This is one. And I have a questions that throughout the maybe webinar we didn't touch base on, which is infertility and egg freezing for non-married female. Shall we consider endometriosis in the decision making or not? And we just consider it based on age and preference throughout the journey.
Let's speak about Saudi Arabia, but I'll leave Dr. Sufyan to comment about Europe country. Saudi Arabia, we are following fatwa, and there are coming always about egg freezing, about semen, and this one especially related to this issue. Now, the age of marriage is delayed in Saudi Arabia, and endometriosis has a long journey actually until sometime diagnosed to be operated, and we are looking for good quality of egg. I think such issue, if we raise it to Dar al-Ifta in fatwa from Muslims for that one, I think once we have a huge number of patients with endometriosis. So I think if we raise that issue, maybe they will agree, but we have to give them the whole data, the whole information, the proper diagnosis, and freezing. I think it will be because doctors can advise, but the right person is Dar al-Ifta. I leave Dr. Sufyan to comment about Europe country.
In Europe country, the eggs freezing is now societal. And for example, in France, we have bioethics law. And in the bioethics law of France, it is strictly written that each woman can and may have eggs freezing, whatever his age. And when you have endo, it is now a kind of guideline to do it because we know the impact of endo on the eggs quality and the eggs quantity. And that explains why now when you are a young woman and you have endo, if your ovarian reserve is low, you can perform the egg freezing when you want and as you want.
Sorry to comment. I think, yes, egg freezing is one solution, but I think if you put the name on the disease as early as you can, you might save the fertility without maybe going through the preservation. What do you think, Professor Sofyan, from this point of view?
It's an issue of awareness. In fact, when you have an information very early, you may inform the patient, you may counsel the patient. And if you are a patient, you may drive your life at this moment because you have this information of endometriosis and also of the risk of infertility in this position.
If I may add, Dr. Samir, out of personal experience, it is not widely available, but several of my patients, single ladies, did freeze ovaries, did freeze eggs. They're all endometriosis patients. It's available in the public sector and some of the private sector as well. And their experience has been good so far. I think, as you said, having the input of the هيئة كبار العلماء أو مجمع الفقه الإسلامي would really encourage people because they seek the religious aspect of that as well and would increase the number of people who are doing this and benefiting from the already available services in that aspect.
In practice, this refers to one issue, which is the expert center. What is an expert center and what is the methodology in your country to build a new expert center dedicated to the diagnostic, to the treatment, to the fertility, and all those issues in the same place at the same moment. And I think if you are able to build this, it will be very easy to answer to all these questions for all those patients.
When I compare, actually, we compare in Dar al-Ifta and those one, it's allowed for cancer patient to do freezing. Endometriosis, sometimes it's more worse than cancer. So I think if they have the proper information, the proper investigation, I think maybe they will agree. So this one depends, but we should have all the approval that included history, diagnosis, lab test, and the issue behind that. I think maybe they will agree, but it should be some carry the flag and actually give them the right information. And I'm sure they are highly cooperative. I think now it's a time to leave, but on the same time, I'd like to thank all our speakers. It's very interesting webinar. Thanks for all our patients. We feel sympathy with our patient. It's a unique webinar sharing all the patients. I would like to thank all speakers. I would like to thank all the participants. Before we go, I leave each of the speaker to speak and Lena and everybody for 1 minute or 2 minutes to add any more point which you miss. We'll start with the youngest, Dr. Mujahid.
جزاك الله خير. والله لا شيء يقال بعد ما قيل يعني الله يجزاكم خير. Very interesting, and I hope this is an eye opener. I'm personally quite interested in this endo test, and I think it will be really a game changer in the very, very near future.
Dr. Ahmed, since you are from the lab, you look younger than Mujahid, but we'll give you that you are older.
Assalamu alaikum. I'm 40 years old, doctor.
I'm young.
Oh, you look young.
Yeah, no. I'm 40 years. Really, I'd like to thank all my professors. Thanks a lot for meeting you. I'd like to add that ZEWG endo test is present in all Al-Farabi laboratory branches, and the results will appear through salivary sample within 16 to 18 days maximum.
Lena, because she's a lady, so she will be before.
Thanks a lot.
First, I would like to thank all of you for this webinar and the contribution and the organizer and you, Dr. Samir. I just want to say that Saudi, one of the message that it was sent to all the world that the health of women is very important. Woman is essential pillar in the world of bringing Saudi Arabia and improvement and advanced. And I think one of this is what we discussed today, that we are focusing on the health of women, and I thank you for that. Thank you very much, all of you, and I would like to thank Professor Sufyan and all the professors and Dr. Majid and Mujahid for all what they said. It was really great webinar. Thank you very much.
Thank you. Yes, Professor Sufyan.
I just want to conclude that Arabia Saudite now is the headlight of the world, especially because I visit many countries since now 2 years ago. And what I see is in your country, you are aware about what is game changer, what can change the life of many millions of women. And thank you for that.
Thank you very much for our speaker. Thank you very much for all our participants. Today is Friday. It's a weekend. We have more than 3,000 now hearing through webinar. I would like to thank all of them. Some of the people, they try because our webinar is only for 3,000. So I would like to thank everybody who joined us. And I would like to inform you that we are going to have another endometriosis session in 1st of March. It's going to be live surgery, and with the speaker, we are going to organize, and we are going to be one of the hotels, and it's included also through a webinar. So people who could not attend, they could share with us, either attending or through a webinar. And we are going to have a live surgery on it. And Dr. Prof. Sufyan, he is going to join us in 1st of March in Saudi Arabia. And so welcome everybody, join us and see you again and again. We have our activity that's including Saudi Women Health. In May, we're having hysteroscopy, laparoscopy workshop, and we are doing a lot of activities with our colleague. So thank you very much. I would like to thank Tamr. I would like to thank all our speakers, and I would like to thank everybody who shared with us. Thank you very much, and see you again and again.
Thank you. Thank you. Bye-bye.
Thank you very much. Bye-bye.
Bye-bye.
Thank you.
Thank you.
Thanks a lot, Dr. Samir. Assalamu alaikum.